That is not scaling up, in my opinion. It
Yeah.
has remained, it's sort of again plateaued off, I feel.
I'll share my experiences.
Why so?
I'll share my experiences and what we have been trying to do and what are the challenges we have faced. So, coming back to the drivers which you mentioned, Ayushman Bharat and the PPP, whether they have plateaued or they are not, good enough to push the agenda which they had been initially started off. So to Helmut's point, I would agree with him that we need to still give time to Ayushman Bharat as a scheme. I sincerely believe that it's a fantastic scheme, which has given potentially a chance to a population as large as almost 500 million people of this country, some money in their pocket to go and get themselves treated, which never happened earlier. So, that is something very positive about this scheme. In the last 5 years plus since the scheme has been launched, we have seen at least 3 revisions in their package, in their packages, rates, packages, etc., which are now evolving. And the very
Is it downward or upward?
upward towards betterment.
Good.
And let me also strongly put this particular point that whenever everybody, there's this common factor that the service providers say that Ayushman Bharat rates are not good enough for them to enroll and have patients in their hospitals covered under the Ayushman Bharat schemes. Now, let me ask this group, who are these players who are saying this thing? A handful of corporate hospitals. They have the voice, they have the presence, in the forums where the policymakers sit, in the forum, they have the visibility. So they have created this kind of a narrative that Ayushman Bharat rates are not good enough. But trust me, that's not the case.
I think it's music to my ears.
It is not the case.
I will second this point because the private medical colleges where the people were not able to pay, they are very happy. They were seeing the patient free of cost. But now they are saying that they are getting a reimbursement from government. So private medical colleges are very happy. What you say is very much correct.
Yeah.
Whether it is a FICCI forum or any other forum, we spoke about the insurances, you spoke about Narayan Hrudayalaya, you spoke about a Manipal group, you spoke about Apollo. So who are these? These are the top corporate hospital chains in the country. The cost of treatment, basic cost of treatment itself is very high there. In the name of quality, in the name of the treatment they want to give to the patient or the ambience they want to create in their hospitals.
Plus 20% IRR is
plus whatever. That's it. So the point is, let's walk down to the healthcare facilities in tier 2 cities, in tier 1 cities. And trust me, we'll find ample players who are happy with the Ayushman Bharat schemes. They are enrolling themselves as service providers, as clinical service providers for these schemes. And yes, as he said, let's give some more time. A scheme of this scale cannot show results in 3 years or 2 years or 5 years for that matter. We need to, and India is such a diverse country. The kind of diversity we have in this country, I think nowhere in the world we'll find this kind of a diversity with the kind of numbers we have in terms of people. So we need to give this kind of a time period for at least 10 years where, let's say, 80% of the 500 million targeted would genuinely be covered by this. I'm not saying that they have been covered, the 500 million people today. I think I don't have the latest numbers, but somewhere just around, I think 100 million people who have been covered under the scheme of Ayushman Bharat, who have got the cards and everything. So this is
key or net health and all. It is not the 95%. If you look at the patients, it's 5% patients are only treated in corporate. Yeah, sorry.
A lot of points I'm saying more as a citizen of the country, rather than a representative of an organization, because I have the access to the discussions, where you can see from both the sides of the. Coming to the PPP thing, especially in the cancer care, we have been talking to both the central government as well as the state governments, health being a state subject, and you talking about the YSR scheme being expanded to, unfortunately, that is not possible because health being a state subject, no two states are willing to talk to each other. That's the challenge. So to carry a best practice from one state, let's say a state of Tamil Nadu, a state of Kerala, to an extent even Karnataka for that matter, and Andhra Pradesh, they have kind of one of the best healthcare infrastructure in the government setup. You know, I mean, Tamil Nadu is a model state when it comes to government healthcare infrastructure. However, Assam Cancer Care Foundation, which has been a partnership between Tata Trust and the Assam state government, you know, this is a model state now for delivering cancer care services. And the secretary in Assam, yeah, and the secretary health has many a times in the meeting where I was also present, has asked his people to go and study the model there and has encouraged the states to go and emulate that model in whatever best way they can do. But unfortunately, they can do only as much. The willingness, people down the line, you know, that is also something which needs to be done.
A federal system has an advantage. It's a competition of the best ideas. And when you look at the size of your states, 60 million in Karnataka or something like this, that's enormous, absolutely enormous. So a system that runs here is a value in itself. And if you have other 50, 30, Scandinavia is 8 million people. Yes,
I
think it's
But I
something.
think what, Assam is just one example though, because we were there helping plan this and we got all the oncologists together. We mapped out the workflows. They standardized on these things, but the secret sauce was Tata Foundation paid for it.
And it's high cost, and it's high cost.
So-
It can't be replicated
Yes.
in other states.
Yeah, well, it could if the government
Yeah.
was willing, that's the thing, willing to take a standardized, well thought out, operationalized.
I tell you something, you know, I'll tell you the story behind that also.
Mhm.
Tata Trust was mandated to, you know, for 400 cancer care centers across the country. That was the mandate given to Tata Trust, you know,
By whom?
by the government of India. By the government of India, and as part of their philanthropy efforts.
In a quid pro quo exchange for other things, okay?
Nothing happens, you know, you scratch my bag, I'll scratch yours. So nothing happens without that for sure. However, you know, we were part of that arrangement, you know, where we signed an MOU for 200.
You guys were there with us, yeah.
We signed an MOU for 200 units of linear accelerators with them. Unfortunately, that number just got stopped at 18.
18.
18.
Oh, 18.
Yeah, 18. Not even 20. Not even 10% of what initially was signed for. Because the leadership within Tata Trust got changed. The
But that
focus
was-
got diluted.
That was for a different reason, right?
Whatever, we know. So the point is that it's not that it was initially meant to be replicated across multiple states. I mean, they had signed up MOUs with state of Odisha. They had signed up MOUs with Jharkhand state. They were willing to talk to other states also. Bihar also they had gone there. But because of the, you know, the whole plan fizzling out for multiple reasons, it couldn't be replicated beyond Assam.
And also the oncologists demand that I don't want to take companies' names. I want only this company, which is 1.5 times the cost of what is possible. And of course, the level of equipments, we talk hub and spoke, but is it really hub and spoke? Every spoke became a hub and became very expensive. So it was not hub and spoke. Hub and spoke should be very clear. What a spoke will do, what kind of technology will be there, what will not be there. If every spoke becomes a hub, it's impossible to, and this is where NIF, the company which has funded us, is working.
We are also working with NIF.
Yeah,
actually.
sure. Of
We
course,
are
with
also
everyone.
working with
With
NIF.
everyone.
And
So
they are the ones, you know.
Yeah.
I think the point is that it could happen.
It is possible, for sure.
Yeah, I think that's your takeaway is these things can happen if the right people get together in the right room. What Helmut was saying, the stakeholders across the places that people can say no. The wall of no's that could, be there. But I still think the going back to, it's kind of like the Chinese baseball cap, the label inside, it said one size fits most. And our problem in healthcare is we try to build one model that could fit most. But there's so many different scenarios. And I think this is the problem with the Ayushman Bharat is it's like, here's the price you get for this patient situation, but patients show up with comorbidities. Patients are not ends of one, or they're ends of one, not. And so therein lies the challenges of which, how do you apply these rules and structures when
There are around 25
NHA
countries
today,
that correct for this.
NHA
There are models for
Yeah,
this.
yeah, exactly.
Patient mix, you can risk compensation. One insurance have elderly, more morbid patients who want to skim only the young ones, how to compensate. It's all there.
Yeah.
Some of those articles are in Polish. Who speaks Polish? So our job is to make this known. And there is experience in small countries, 20, 30 million only.
I think Singapore has done a great job
Yeah.
in this.
So to continue your narrative, so where is the PPP and hub and spoke model of cancer care?
In reference to the radiotherapy treatment in the cancer case, if I just talk about, we all know about the challenges we have, about the availability of the facilities we have. Today, WHO suggests we need to have 1 per million population in terms of linear accelerator, whereas we just have about 700 linear accelerators functioning in the country. And 85% of them are available in the private sector. The geographical skew is that less than 20% of the districts have this facility in the country. So everything is a challenge. People have to travel. As they say, 18 to 20% of the patients in India are able to get the radiotherapy treatment. Whereas in developed countries, the number is as high as 50% of the cancer patients. So we have and without government, it is almost difficult, almost impossible to scale up the facilities without the intervention of the government. I mean, that's the way we are designed as a country per se. So we have been talking to the Ministry of Health along with Niti Aayog that why don't we look at, let's say, target 300 districts in the next 4 to 5 years where we have these facilities available. Now, if the government consolidates this kind of a requirement or creates this kind of a program in the country, then obviously they have, and the secretary has agreed that yes, this will help us, get players to start localizing the technology, which is not happening today the way it should be. This will also help in the training aspect of the skilled manpower. It is not only about the radiation oncologist, but also the paramedics, the technicians who need to run the machine per se. So a medical physicist is a large chunk of players who play a crucial role in the radiation therapy treatment. So considering all these things, these can be then looked. Let's say if the government consolidates their requirement, let's say we will buy, let's say, 400 equipment in the next 4 years or 5 years. Companies are willing to, and off the ground running clinically, then the emulation can be much faster.
Let me throw some question at you at this point of time only. Is that I'm happy that you are doing a fantastic trying to do that heavy lifting for the model to work. But one more dimension which needs to be looked at is that can this cost per therapy per sitting, can that be drastically brought down? And what are the barriers and how it can be brought down? Not just by reducing the cost of linear accelerators. There must be multiple things which go into that cost per therapy. And unless that is reduced, the speed with which this can be scaled up will be slow. But if that can be reduced, in my opinion, I think the whole expansion of the number of people who want to set up these centers will go up.
The only thing which I can say at this particular point is that the Ayushman Bharat rates for, let's say, therapy, radiotherapy, are almost 50% less than what normal private hospitals charge from the out-of-paying patients, pocket-paying patients. And there are, facilities in tier 2 towns, tier 1 cities also, where hospitals are offering treatment on these rates. It is not that this cannot be done or this is not being done. Maybe at a smaller scale today, but definitely it is being done. However, this needs to scale up dramatically for sure. And this would come when, let's say, there is an encouragement of clinical service providers to be part of that arrangement under PPP. Because PPP rates, the benchmark again, either is the state insurance schemes or the Ayushman Bharat. These are the two benchmarks normally whenever a PPP financial model is being talked about. So there is a willingness, it's just that if some support comes in, the clinical service providers would surely feel encouraged to kind of have these services provided at the agreed rates with the government, which we are almost 40 to 50% less than a normal private hospital charging for it.
But if you said, let's scale the country with, in this case, radiation therapy, but it could be any of these kind of things, right? And you said, okay, here's our as-is cost today, siting costs, equipment costs, skills, manpower costs, consumable costs, electricity and all these things, right? You could go after those today and you could say, I could cut this one by, 40%. I could cut this one by 10% because there's not much left. I think that's the part maybe that Prasanna's getting at is that if the government tomorrow said no more sales of whatever, because you have to come in at this different cost position, it would be the forcing function to go back and say, what could we do now based on this? And together with the governments, I still think there's incentives the government could do, like they've done in other countries, to set up local manufacturing, local supply chain, tax and duty structures that could also encourage people to come and domesticate these technologies in a different way.
Government has done that, and PLI scheme has been a classic example. And radiotherapy equipment were a focus, part of the PLI scheme. And I was part of discussions of many such meetings where the bureaucracy, insisted that we start manufacturing in the country. But unfortunately, as I mentioned, that the market size is also one of the basic key drivers for.
They'd have to come and say, we're going to scale the country to do this, right?
That commitment is still not coming here.
Yeah, that's what we're saying the same thing.
Yeah.
And to your point, Terry, we'll have to watch closely what Kakino's is promising. Is that center, you're talking about the facility providing care, do they have to do everything? Or is there a way to distribute that?
Yeah.
Kakino's as a platform, Prasanna, you
Which is the Tata Foundation had that did this.
Watch, we are working with them, and it's too early to say for me to done that we are. But it's an interesting model to bring in and shared capabilities and not overwhelm the cost of everything that you said, even from technology to the capabilities, the skill sets and everything. I think a lot of nice work is happening, but we'll have to see how all of this is coming out.
Is also focused currently. Whatever discussions I have had with them, the feeling which I could get was they were also focused on setting up brownfield projects, in the existing hospitals.
That's the one part of Kakino's.
That's one part of it. So maybe I was part of those discussions. So,
I'm talking about Kakino's trying to create, an oncology facility which is, less costlier to, run, and thereby pass the cost. Is the other part which we are trying to do. And of course, GVS should talk about what he's trying to do from a technology actual cost. We're talking about a company already. How much of that is being promoted? How much of that is going to, because he's going to, GVS, I should not talk on behalf of you, but
localize the technology. We as an organization have tried, to make an arrangement of transferring the technology on a license-based arrangement with one of the PSUs in the country. But again, the eventual challenge that PSU faced was that where would they sell the equipment? Because there was no commitment per se. And the current requirement of, let's say, 70 odd units which are being installed every year is being met by the existing supply chain systems of the companies. Even if it gets double tomorrow, we are still equipped to meet that requirement. So the government has to come up with some kind of a program. We have also reached out to multiple states across the country. I have reached out to 18 states now, right from northeast to southern part of the country, northern and central part of the country, to seed the concept of setting up radiotherapy centers on a PPP basis. I know it is not, it cannot be said as an apple-to-apple comparison between a radiology diagnostic center or a pathology center, which has been a huge success in the country on PPP based model. It is not the same because the patient doesn't get scanned once and goes away. The patient has to come multiple number of times. So the whole dynamics of setting up a radiotherapy center is different, and it cannot be set up in an isolation. It has to be supported by a surgical department or maybe a medical oncology department within the setup where we wish to set this up. However, the challenge is the cost of setting up a radiotherapy center. VGF can play a huge role in making this model in radiotherapy a huge success. Viability gap funding. Viability gap funding.
Yeah, correct.
Now, viability gap funding is a concept which is permitted by Ministry of Finance, but has to be tapped by the individual states, for these kind of projects, which unfortunately doesn't happen. Thankfully, NIF is doing this job.
In UP and Jharkhand, they have been able to, and they want to do it in 10 states.
And 10 states, yeah, Rourkela side of Jharkhand, where it is mines and everything. So VGF is a potential arrangement available with Ministry of Finance, where they are willing to fund up to almost 40% of the cost of the project as part of viability gap funding. And this would definitely help a lot of clinical service providers to feel encouraged and be a part of. Let's say today, if we think of setting up a radiotherapy center, we can look at amount of almost about 40 crore rupees, in terms of INR, So that money, not everybody, the top players, the corporate players, they have enough on their plate in terms of their existing facilities. Those who are aspiring to go beyond whatever they have, they do not have that money power, and this kind of a facility will definitely encourage them to come and be part of these kind of processes. So yes, we are hopeful that, with kind of some needle moving in the right direction from the Ministry of Health, some kind of project being accepted by, support from NIF, etc. We are hopeful that, in a year's time, we'll have a few states coming up with these, projects. And, maybe today we only have one center being run on PPP in Rajasthan for radiotherapy. I sincerely believe that if we have 2 or 3 centers up and running, emulation will be much faster. That is how I sincerely. It's just a matter of 2 or 3 centers, coming up.
I have a couple of questions for everyone here after the discussion that we have got. Vineet has provided a lot of information from the ground, which because he has a lot of experience and he has first-hand experience. First point that he made is that Ayushman Bharat is viable for a healthcare provider. If you leave the few corporates out, Ayushman Bharat is actually a viable business for all the healthcare providers. Now, if you take that healthcare providers who find that it is viable, and there are patients who can pay from their pocket, they would obviously pay. Ayushman Bharat, for the information of some of you who know the value, pays about 1 lakh rupees per IMRT treatment. VMAT treatment, and if that is viable for a caregiver, and if there is a out-of-the-pocket patient who can pay on their own, they would pay at least 1 rupee more than that 1 lakh rupees. Is obvious, right? Otherwise, they would have already got themselves into that scheme. So if 1 lakh was viable for many players, why are we debating this? Why are we asking government to go and say, okay, you give me fund, you give me your patient, you give me this oncologist? How many oncologists are there in the government versus how many oncologists are there outside the government? All of those oncologists would actually go and run a Ayushman Bharat scheme, and they wouldn't actually go and join Narayan Hrudayalaya, for example.
Yeah.
And what happens? You've solved the patient's problem.
Yeah.
And these patients are, these oncologists are very eager to go back to their hometown.